Hello, my name is Joetta Elkins. This is a PowerPoint presentation on my quality and safety improvement project through Davis and Elkins College. The project goal is to reduce nurse and CNA burnout. Our team members include myself, sponsor Autumn Posey, expert Kimberly Swiney, administrator Courtney Major, and Shanda Jeffrey, our inpatient administrator. Our global aim was to reduce nurse and CNA burnout in our inpatient hospice unit in our facility. By working on this problem, we should retain experienced hospice staff, and this is important because our facility is experiencing high staff turnover. The World Health Organization defines occupational burnout as a syndrome resulting from chronic workplace stress that has not successfully been managed. They include three dimensions: feelings of energy depletion or exhaustion, increased mental distance from one's job, feelings of negativism or cynicism related to one's job, and reduced professional efficacy. Baseline data included 19 interviews with CNAs and nurses asking questions about whether they felt excessively stressed or excessively tired or exhausted, whether they experienced negative feelings related to their jobs last week, or if they felt a decreased ability to perform their responsibilities last week. 16 of the 19 staff answered yes to at least 3 of 4 of these questions. That's 84.2% of full-time nursing and CNA staff having had recent feelings of burnout on their unit.
Contributing factors to feelings of burnout within the CNAs and nurses on our unit include highly emotional specialty of hospice, inconsistent documentation and charting processes. We use paper and electronic health records. Um, Acutely ill patients in pain crisis, patients with irretractable nausea and vomiting, patients in behavior crisis, respite patients requiring one-on-one care due to dementia, and just the way they're handling the change in their situation while they're in our care for respite. Patients with housing and family crisis awaiting long-term care placement. These patients are not necessarily always inpatient hospice appropriate due to their restrictions, but we know that finding placement for these patients can often take months. Families with extensive needs, education, clergy, social work, um, that can add stress and a lot of time. Our patients' families are seen as an extension of our patients, and we do our best to provide the best education and care for them possible. And also just the overall fear of losing our licenses due to a lack of resources to ethically and responsibly care for these patients and their families. Current, current literature includes a 2021 survey of 50,000 plus U.S. registered nurses. Of those nurses, 9.5% reported leaving current employment, and 31.5% of those nurses stated that they did leave due to burnout. Our readiness to change was established as we worked together to find a clear focus and obtain leadership buy-in through the project approval of our inpatient administrator. We brainstormed a solution that would benefit the staff, patients, and families, and we collectively agreed to eliminate blame amongst individuals to focus on the system change that we would like to implement. We analyzed data collected from staff interviews, and all team members agreed to participate for optimal outcome. The specific aim and timeline of our project was to reduce nurse and aide burnout by at least 30% by November 25th, 2025. Our change idea was to create a tool to measure patient acuity. Staff was to update this tool at the end of each shift and use the measurements to create assignments rather than assigning patients by hall.
Our outcome measure was to do follow-up interviews with staff 7 days after implementation of the acuity-based assignments. Balancing measure increased time and physical steps to reach patients located on separate halls rather than having patients room nearby. We will ask the nurses if they feel as though this increased time and effort caused them more stress than caring for patients by hall despite acuity. Our pilot test included staff training and involved all team members and collaboration between shifts. And we used a tool for staffing assignments from November 13th to the 20th of 2025. This is a sample of the acuity tool that we had the nurses fill out at the end of each shift. Our barriers included limited data that was available regarding nursing in the inpatient hospice facility, some resistant staff, multiple high acuity patients on each hall that a lot of times made it difficult to change the assignments to level them out, and training for different shifts because we all kind of work different shifts and different days. The outcome included follow-up interviews with the same 19 staff members, the same questions that we asked as the baseline with the additional time and steps question. And 57.89%, 11 out of the 19 staff interviewed answered yes to at least 3 out of the 4 questions. That's a 26.31% decrease in feelings of burnout. And 31.58% of staff interviewed reported that the extra effort negatively affected their assignment. Ironically, all 6 of these respondents reported feelings of burnout at both baseline and the follow-up interview. And these are my references, including the study of the nurses and the definition of burnout from the World Health Organization.